welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, the 2018 Plan First and Patient First Protocol Updates. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, handouts are available online, and a link to the post-test in LCMS will be posted after the program. You will need to register for this program in order to access those materials. This program will also be posted on demand if you have questions in the future and would like to review any of the material at a later date. I'm Meredith Adams, Director of Social Work for the Bureau of Family Health Services, so let's get started. Thank y'all for joining me today, and we've had a few protocol updates throughout the past year. So I just wanted to stop for a few minutes during our morning this morning and go over those with you. Our Patient First and Plan First have both decided to make all the questions in the psychosocial assessment, those all have to be answered. So on your risk assessment and in your psychosocial assessment, all questions now have to be answered. And you can put NA on those if you don't have a specific answer to the question, and then you can go back at a later date and change the answer if you need to. This was done because of a request from Medicaid. It was primarily in the Plan First program that the change needed to occur. They requested that since the psychosocial assessment was being completed, that all the questions needed to be answered. They didn't like seeing blank questions, so that's why we had to go in and make all questions required on that psychosocial assessment. And one thing that we try really hard to do is if there's a requirement in one program, we want the same requirement in the other program. So that's why we did it for Patient First as well. So if you don't have an answer to a question, we've got NA on there for you to go ahead and mark NA. And you can change your answer at a later date if you need to. Another change that's been made for Plan First is the Medicaid flip list roster. That maternity contact page that we've been using, we're also going to start using that for the flip list and the Medicaid roster. These forms are going to be due to your manager and or your director by the 6th of the following month. And all that was changed was in the title of the patient contact log that you've been using for maternity. We've added flip list and Medicaid roster to the title. And then in the high risk column, we've changed that to add or NA for maternity patients. Because if you're working the flip list or the Medicaid roster, you may not, if it's the Medicaid roster, the patient's probably not been pregnant. So the high risk question doesn't apply. But if you're working it for maternity, we still needed that on there. And with the flip list, you may not know the status of the pregnancy that's occurred. So we put an NA on there. I didn't want you to have to fill out two separate forms for them, so we just kind of made it work. So you can complete this form for all of your Plan First maternity contacts that are referred to you from the maternity care coordinator. And you can use the same form when you're working the flip list and the Medicaid roster. Medicaid has been questioning the number of patients that have been coming in for Plan First. So they're trying to increase the number of patients that are being seen throughout the state. So we wanted a way to capture all of the outreach that the health department's doing. And you, as the case manager, are doing the majority of that outreach. So we wanted to capture the work that you're doing so we could show that to Medicaid. So that's why the form's been updated. And hopefully all of these contacts can be kept on the one form. The next protocol change for Plan First is a result of the MOU. Medicaid and ADPH renew the Plan First MOU on an annual basis. This is the document that allows us to provide clinical services and case management. Medicaid put into the MOU that they were requesting supporting documentation for our 15-1 time, our recruitment time. The way that you work Plan First right now, when you bill to anything except 15.1 or code that time to anything besides the 15.1, that time is sent over in what's called a claim to Medicaid. And it's got the Medicaid number, the patient's name, the date of service, all this great information that gets sent over to Medicaid. The 15.1 time was sent over on something called an invoice. This invoice just lumped it all together. Meaning, if you saw 10 patients today and coded 5 of them to the 15.1, that time was grouped together and sent to Medicaid as a total. So they would just get an invoice for the month of April, May, and June that said we had provided 20 units of 15.1 time and a dollar amount attached to it. They wanted some more supporting documentation. They wanted it to look more like what we do for the rest of our billing, which includes the Medicaid number, the patient name, the date of service, all of that supporting documentation. They put time frames on when that had to be sent over, and it was not going to be possible for us to meet the required time frame with the way that was being billed. So we decided to talk to them about it and see, would it be possible, could we negotiate on that 15.1 time? Would there be a way for us to still do that without meeting the time frames? And that didn't work. So what we decided to do was I looked at the risk assessment and I was like, you know, the risk assessment requires us to mark that the patient accepted services. That occurred several years after the program was developed. Medicaid requires us to offer case management services to the patient. Well, several years after the program started, the risk assessment was updated to include that documentation of the patient accepting or refusing services. So it's on the risk assessment. So went to Medicaid and said, you know, this is on the risk assessment. Would that be sufficient to show that we've offered case management services? Because Medicaid really didn't want an additional billing process, just like we didn't want an additional billing process. So Medicaid said, you know what? That works for us. So we are going to turn off the 15.1 in ACORN. That means that all face-to-face time spent with the patient for the risk assessment, including offering case management services to the high-risk patients, will be coded to 15.6. So you still have to offer them case management services, which, how do we do that? Well, let's say that the patient has chosen Depot as their chosen birth control method. So you'll say, I see that you've chosen Depot. I'm going to call and remind you about your Depot appointments. Do you prefer that I call or text you? Well, when they say call, they just accepted services. So that way you can mark on the risk assessment that they accepted services. And all of that face-to-face time is going to be coded to the 15.6. And we have a question in the room.
Well, just a statement. March 1st, that's when it goes into effect.
Yes, I hadn't gotten that far yet, but thanks. The high-risk assessment is coded to activity type 6. All time associated with the face-to-face interaction with the patient during the annual family planning risk assessment will be coded to activity type 6. All time spent completing the psychosocial assessment and any face-to-face time with the patient during that annual family planning risk assessment will be coded to activity type 6. No more than 2 hours per patient per year can be coded to activity type 6. Per year, we can only do an annual family planning risk assessment one time per calendar year, such January to December. Now, if you do a low risk assessment and they come back in and request services, you can then do a high risk assessment. You'll have to reassess them and code to the 15.6. So in a few cases, we could do more than one risk assessment during the calendar year. Doesn't happen often, but there is a contingency plan for that in case it occurs. So again, all face-to-face time will be coded to 15.6. So that face-to-face time is to the 15.6, and all documentation will be coded to the 15.4. This means one less SSR entry for new high-risk patients. That's a good thing. I know it's not a whole lot, but every little bit, I hope, is helping. So that's one less SSR entry that you have to do for those high-risk patients. So again, all face-to-face time with a high-risk patient in Plan First will be coded to 15-6. And like Bill said, this is going to go into effect on March the 1st. Pretty sure that's Thursday. So Thursday, March the 1st. You're going to continue doing things just like you are through Wednesday, close the business. I'll send an email out on Wednesday afternoon, February the 28th, letting you know of the protocol change. All protocols will be updated on the document library, and I'll get that sent out to you late Wednesday afternoon so that on Thursday morning, March the 1st, 2018, you'll have the copy of your protocol right there telling you that the 15-1 has been turned off. So I just wanted to take a minute and go back over our Plan First coding. Just as a reminder, the 15-2, this is for face-to-face time, not in conjunction with the risk assessment. No more than 2 hours per patient per day. The 15-3 is for successful phone calls with the patient. No more than 1 hour per patient per day. The 15-4 is for documentation. No more than 1 hour per patient per day. The 15-3 and the 15-4 are going to the same CPT code. What does that mean? They add together. So if you're coding to a 15-3 and a 15-4 in the same day, the time cannot exceed 1 hour. The 15-5 is our low risk assessment. No more than 2 hours per patient per year. Because again, this is an annual family planning risk assessment. So that's why there's a yearly limit on it. The 15-6 is our high risk assessment. All time associated with the face-to-face time with the patient will be coded to the 15-6 during that annual family planning risk assessment. No more than 2 hours per patient per year. The 15-7, that's our case closure code. There's no time associated with the 15-7. And the code we added sometime last year was the 15-9. This is for the unsuccessful phone calls to the patient and the documentation. No more than 15 minutes per patient per day. The 15-3 and the 15-9 are dealing with phone calls to the patient. If you're calling a provider on behalf of the patient, that will be coded to the 15-4. 15-3 and 15-9 are reserved for contact specifically with the patient. So the 15-3 is for successful phone calls and the 15-9 is for unsuccessful phone calls. Do you have any questions related to the Plan First protocol change or any Plan First questions in general? So I'll kind of give you a minute to think through that and see if you have any questions, so we can try to wrap up some Plan First. You can still call in at the end of the program if you'd prefer, but I wanted to give you a moment if you had any Plan First questions. So just as a reminder, we're going to be turning off the 15-1 on March the 1st. You no longer have to code to 15-1. All face-to-face time with the patient for the high risk assessment will be coded to the 15-6. We do not have any email questions, and we don't have any phone calls, but if you have a Plan First question, you're welcome to email or call in while I continue on with the Patient First changes. We've made several changes to the lead protocol. The main thing we did was we changed the structure. In reviewing the lead protocol with Patient First, we noticed that it kind of jumped around between unconfirmed and confirmed lead levels. Well, I don't know about you, but that was rather confusing to me personally. So we spent quite a bit of time going through and grouping the protocol together so that the unconfirmed protocol and the confirmed protocol were in the protocol together. So I'm hoping that the flow is better for you now that we've kind of done that. I know it helped me out personally to understand what was going on. Just to give you a little bit of vocabulary testing here, there's two types of testing methods with lead. A capillary is a finger stick. That's where they simply stick the patient's finger. And sometimes if they don't clean that finger real well, it can give you a high lead level, which is why the venous testing is the preferred testing method. And whenever I'm talking about venous testing, I always point to my arm at my elbow. So I'm assuming that's where they take the blood. But again, y'all, I'm a social worker. I'm not a nurse. I became a social worker for a reason. I don't like blood at all. So I think the venous is done in the elbow. Pretty sure that's where they do it. And you can just imagine trying to draw blood on a 12 or a 24-month-old. Not a fun task. So that's why they usually do the capillary testing, which is the finger stick, because it's a lot easier to do. But remember that the venous testing in the elbow is usually the preferred method to get the blood draw for lead testing. So what's our goal with lead case management? Well, we want to ensure that those unconfirmed blood lead levels receive follow-up testing. And if we have a venous blood lead level, we want to decrease that with 2 consecutive tests of less than 5. We also want to educate families on lead hazards and eliminate the lead hazards that are in the child's environment. So let's first talk about what we do with unconfirmed lead tests. Unconfirmed is 1 capillary, again that's going to be that finger stick, of greater than or equal to 20. A missed appointment to repeat an unconfirmed capillary specimen. These are usually the 2 reasons we will be referred an unconfirmed lead test. The goal with an unconfirmed lead level is to have the child come back in for confirmatory testing completed through a venous specimen. And again, venous is the blood draw, so I'm going to point to my elbow whenever I'm talking about it. Capillary, I'm always going to point to my finger. So we want to have that confirmatory testing, and the best method for that is going to be with our venous sample through our elbow. If you receive a confirmed lead test referral, that's usually going to be a venous specimen of greater than or equal to 5, or 2 capillary specimens of greater than or equal to 10. So if they've had 2 finger sticks that are greater than or equal to 10, we're going to be referred that patient, and we're going to follow our confirmed lead level protocol, just like we would with a venous specimen of greater than or equal to 5. So what do we do for those confirmed lead levels? Well, we need to do a home visit because we need to figure out what's going on in the home. When you receive a confirmed lead level referral, automatically know you're going to have to go to the house and check and see what's going on. We want the home visit to occur within 2 weeks of the referral when the level is between a 5 and a 19. When it's between a 20 and 44, we'd like for the home visit to occur within 1 week. When the confirmed lead level is between a 45 and 70, we need you to go out within 48 hours. If it's greater than 70, we ask that you go out and do the home visit within 24 hours of the referral. However, if you receive a lead referral of greater than 70, most likely that child's going to be sent in for chelation therapy, and usually that occurs in the hospital. So you may not be able to get that home visit done within 24 hours because they may not be home for that to occur. So if that happens, be sure that you document in the record that you called the family and you attempted the home visit within 24 hours of the referral. But just know that you might not catch mom and dad with the child at home because they may not be there, because a greater than 70 test is very serious. When we have that confirmed lead level, we're going to need to have some repeat venous testing. Again, that's our blood draw. If it's between, the child was referred to you with a level between a 5 and 14, we would like for that repeat to occur within 3 months. If the level, the confirmed level, was between a 15 and 44, we would like for the repeat testing to occur between 1 and 3 months. If the confirmed level was a 45 to 59, we'd like a repeat within 48 hours. A 60 to 69, we'd like it within 24 hours. And if it's greater than a 70, we're going to repeat the testing immediately because they need to know if chelation needs to begin with that patient. We've had a lot of questions about the environmental survey. So when a child is referred to you during the home visit, you will perform an assessment of the child's living environment. And this should be documented on the required form. The form is available on the page with this training, and it is also available in the document library under the Patient First Protocol tab, and it's uploaded there. So you can print it out from the document library as well as access it through the on-demand page for this training. If the child has a level of greater than or equal to 15, an environmentalist will conduct an environmental survey. However, the case manager's assessment should be conducted first. We like for the case manager to go out and assess the environment and complete the form so that the environmentalist kind of has a heads up. If you've gone in and looked at the area and determined, well, it's not X, Y, or Z, then the environmentalist can do a deeper study and survey of the home to try to figure out what that lead level is. If you have a suspicion of what the lead level is, then the environmentalist kind of has a heads up on, hey, I'm pretty sure it's the blinds because I used my little stick thing and dropped the stuff on the blind and it came back pink. So you kind of know, and yes, I can be comical, you kind of know what direction the lead might be. So therefore, the environmentalist can kind of concentrate on that and see, okay, that's probably the direction we need to go, or you know, we really don't have a clue what's going on in this house. So if the environmentalist knows that going in, it's just going to help them out. So we're here to help and see what we can do to figure out that lead in the home as quickly as possible. Once you complete your assessment of the home and that environmental survey, you'll need to send that to the environmentalist so that they have a heads up on that. If the level is less than 15, the case manager will be the only professional in the home. So when you have the opportunity to go out with an environmentalist on a child that has a level of greater than or equal to 15, then it's a good idea for you to pay real close attention to what the environmentalist is doing in the home and ask questions about what to look for so that you can try to assess when you go out when it's less than 15 because you'll be the only one going out. So if you've picked up some tips from the environmentalist, then you'll be able to help more effectively when you have those children that the environmentalist won't see. It's possible that you will receive a direct referral from a physician on a patient with an elevated lead level. When this occurs, you'll need to notify the lead coordinator through completion of the Elevated Blood Lead Environmental Surveillance Form, the FHS 135. You'll fax this form to 334-206-3726. Again, this form is available on the website, on the document library. And there's a reason why I tried very hard to say lead coordinator throughout the protocol and throughout the training, because our current lead program coordinator will be leaving on March the 1st. So we will not have a lead program coordinator effective March the 1st. So you'll still need to fax the forms in, and as soon as we know who your contact with the lead program will be, once we've replaced the current lead program coordinator, we'll notify you of that. It's possible that a physician can make a request via written order on a prescription pad for a home inspection for any child with a lead level of less than 15. Because remember, if the child has a lead level of less than 15, the case manager will be the only professional going out to the home. If the physician makes this request, it should be faxed to the lead coordinator at 334-206-3726. Same number that you send the FHS 135 form to as well. The case manager can also request the survey after completion of a home visit when the lead hazard cannot be identified. It's very possible that when you go out and do the home assessment that you just can't figure out where that lead is coming from. So if you've talked to your supervisor and you have no clue what's going on, and let's say that it's a pretty high level and maybe they've had a retest and it's still not coming down, this might be a good time to talk to your supervisor and see if it would be a good idea to go ahead and ask if the environmental survey can be completed, because the child's level isn't dropping and you've been out to the home and you just can't figure out what the issue is. So you can still request that survey, but you'll have to have supervisory approval, and your home visit will have to be completed and documented on the environmental survey form as well. The other change that was made to the protocol is, when do we close a case? Well, if you have a child that has 2 consecutive tests of less than 5, then you can close the case. If the case has been open for a year or more, a case review is required. Why do we ask for the case review? Well, that's being done so that there's another set of eyes on that record, because this is a child with an elevated lead level. There is no safe level of lead in a child's body. Lead doesn't belong in the body. So if there's any lead, something's going on. So we want to try to figure that out. So if the child has had if the case has been open for longer than a year, then we want some extra eyes in there. Now, sometimes these are really simple, and I get an email that says, hey, Meredith, I was referred this case. It started out at a 45. It keeps dropping. And my response is, you're doing great. Just keep going. We just wanted to see that there's work being done in the case and that the level's dropping. If you're referred a case with a really high lead level, it could take longer than a year for it to come down. The main reason we put this into protocol about 2 or 3 years back was for those cases that were referred at, say, a 7. And they kind of hover around a 5 or a 6. It's like, what's going on? Why is this lead not coming out of the child's body? So that's why we put the case review in. And those case reviews are conducted in consultation with your manager and or your director and or the social work consultant to determine other interventions to consider. So when do we do a report to referring provider? Well, we do that within 30 days of opening the case, or after a lead test is completed, or anytime something significant occurs in the case, like an environmental survey, or when you close the case. So usually anytime something significant happens in any case, we want to send that report to referring provider to let them know, hey, something's going on, so that they're in the loop. So I think we're going to switch gears now to newborn. Oh, we have a question. Sure.
We have a question about, I'm just going to read the question. You mentioned using your stick thing to test the blinds before the environmentalist comes out. Are we supposed to have testing strips, etc.?
Yes, stick thing was a technical term, by the way. You're supposed to laugh. No, you are not required to have testing materials. We have some case managers that go out more frequently than others do, and we've had some samples of the testing supplies that they use, because there's some pockets in the state that have a lot more lead than other pockets of the state. So those case managers are involved a lot more, and they have access to the testing strips. If you only do 1 or 2 lead cases a year, you probably are not going to have access to those testing materials, and we understand that. So if we had some funding, it would be awesome if we could equip all of our case managers with those test strips. The problem is that they can expire and they cannot work after a certain amount of time. So if we blanketed the state with them, it could be a waste of resources. So if you do a lot of lead and you don't have the testy strips, you're welcome to send the current lead program coordinator an email, or you can send the email to me and we'll see if there's anything we can do to get you some. I know in training we just advise if you do a lot and you don't have any, you can go to Home Depot or Lowe's and pick them up yourself, but I don't like asking you to spend your own money for anything. So just shoot me an email if you have a question about that, and we can see if there's anything that we can do to have you equipped with those supplies so that you can be more effective in your lead case management.
Another question, Meredith. When you have a lead referral from a physician and you're doing your electronic referral in Acorn, so your referral source is going to be the physician. Is that correct?
So if you receive a referral directly from the physician, I would ask the physician, are you going to want a report to referring provider telling you what's going on in the case? If the answer to that is yes, then your referral source is going to be the provider. However, the lead program still needs a copy of that report. So you'll need to send an email to the lead program coordinator and let that individual know that a report, you've gotten a referral, but the referral source is coming from the physician, so therefore the report is going to go back to the physician. They need to be aware of that so that they can go in and see that form in Acorn. And it could be that what we ask you to do at some point is print that out and fax it up to the lead program so that they have that. Now, if the provider says, no, I don't want a copy of the report to referring provider, then you can go ahead and mark it as an ADPH central office referral. That way, and mark lead as the medical condition, and that'll go ahead and route it back up to the central office. If you have questions about that when you get one of those, please don't hesitate to email or call me, and I'll be happy to walk you through that process.
And the other question, Meredith, sometimes some counties will receive referrals on 19-year-olds. Will care coordinators be working those referrals, or?
Usually when we receive a referral on a 19-year-old, usually that's an occupational referral. We're still going to send that out, but what we're going to advise you to do is to follow up with that individual. You don't necessarily have to do a home visit because most likely it is, occupational exposure. But we want you to make contact with that patient because it's possible that they are living with a small or young child, or they could be coming in contact with a niece or a nephew. Maybe right after work, the niece has a birthday party and they run over to the house and they haven't changed clothes, or maybe they didn't follow their OSHA guidelines that day because they were in a hurry and changed their shoes. Maybe the 19-year-old has to transport a younger sibling in the car that's sitting out at the lead plant. So we'll want you to follow up with that patient to go over ways to help make sure that the lead is not being given to the young child that 19-year-old is coming in contact with. So it's more of an educational type thing that we would like for you to do with the 18 and 19-year-olds. Now let's say that the 19-year-old is living with a smaller sibling. Then you need to encourage the 19-year-old to tell the parent of the young sibling to have a lead test. Since that 19-year-old is in contact with lead and living with a small child, we would like for that small child to be tested. So the patient needs to tell the parent of the small child, hey, you might want him or her to have a lead test just to make sure that the child is safe. Our goal is to make sure that children are safe. That's what we want. So that's why we're referring out those older children, so that we can make sure that there's not a small child that's being exposed to that lead hazard. Did that help?
Yes.
Oh, we have another one.
We have Liz Todd has sent us an email saying that the lead program is in the process of attempting to obtain testing strips / kits to provide some to at least all care coordinators, as well as sample cleaning kits to use to demonstrate to families how to properly wet mop, etc., to clean lead and contaminated surfaces.
Excellent. Thank you very much, Liz, for that information. We appreciate all the help that we can get with identifying lead sources in the home and how to mediate those. So that's excellent news. Did not know about that. Excellent. Do we have any other questions?
Let's see.
Nope. Okay. Well, we are going to move on to newborn screening. We are finding some questions with some of our newborn hearing referrals. So I just wanted to go back over the protocol about newborn hearing a little bit, just more as a refresher. The key to our newborn hearing referrals, we want you to remember 136. So what does 136 mean? If an infant, a newborn, goes in, when the newborn is born, they have a hearing screen before they leave the hospital. So if the child does not pass the hearing screen at the hospital, we want that newborn rescreened by 1 month of age. If the newborn does not pass the second rescreening, we want that child diagnosed by 3 months of age. And if they are diagnosed with a hearing loss, we want them into early intervention by 6 months of age. 136, rescreened by 1 month, diagnosed by 3 months, early intervention by 6 months. Now, in our, in our protocol, we advise that the first step with a newborn hearing referral is that you contact the delivering hospital. So I wanted to give you an example of why do we do that. And now, my days are not specific. I just picked a random day. So the newborn hearing staff receives referrals from the delivering hospitals, let's just say on Wednesday. So if the newborn failed the hearing screen on Tuesday, those results are reported to our newborn hearing staff on Wednesday. Before the child is discharged, they're re-screened on Thursday. Those results are not reported until the following Wednesday, so the next week. Well, so since we don't have the past results in the system, all we have are I hate using the word, but the failure results. The child did not pass the hearing screen in the hospital. That's all we have. So that child is already what I'm going to call in the pipeline. So that child then goes through the newborn hearing staff process and then gets referred for care coordination. So that's why we ask you to call the delivering hospital first, because it's possible that the past result is a week behind. So it could be that the child's already passed the rescreening at the hospital. We just haven't gotten the results yet. Now, protocol does give you the ability to call the child's PMP or an audiology clinic. There's another option in protocol. The reason we do that is we don't want to pin you into a corner with protocol, because if we tell you, you have to do this in protocol, if for some reason there's an extenuating circumstance, maybe the hospital is understaffed and they haven't had a chance to call you back with the rescreening results, and you go ahead and you make contact with the family and you found out that they're seeing Dr. Smith at ENT Audiology Associates. So you call them. Well, we didn't want it to be in protocol that you had to call the delivering hospital and get the results from them. We wanted you to have an option. Anytime you have an option, it's a lot easier on your OPI audits. So that's the reason why you have an either-or option with the newborn hearing referrals. We're encouraging you to call the delivering hospital first because it could save you some time and some steps. So if the child's passed, we want you to be able to close the case and move on to another family. But that's why we advise you to do the delivering hospital contact first, because it's usually the easiest thing to do and it might be able to get you out of the case a lot quicker. But if you have to call the PMP or the audiologist, then we completely understand that, and that's allowable via protocol. Didn't want to pin you down in protocol. So that's why we ask that your first step should be to call the delivering hospital, because again, those results are transmitted one day during the week. And if the child passed the day after the results were sent, it's a whole nother week before we get those results into our office. And we want to be cognizant of our 136 rule. So we need them rescreened by 1 month of age. And if we waited a whole nother week on those hospital referrals to come in, we've lost another week to get the child in for the rescreen. If the child did not pass the second hearing test at the delivering hospital, then they need to be referred and have a rescreening done. If the newborn was tested in the hospital with the ABR method, the rescreen cannot be completed with an OAE. The ABR goes all the way to the brainstem. The OAE stops at the inner ear. So let's say that the infant was screened in the hospital with the ABR method and did not pass. Well, if the child is rescreened with an OAE, it's possible the child could pass because the issue is in the brainstem, not in the inner ear. That's why we're requesting that if the ABR is the first method used to screen, that the ABR is the rescreening method as well. If they were screened in the hospital with an OAE, you can rescreen with an OAE. But if the ABR was done first, we've got to stick with that ABR method. If the infant failed the ABR hospital screen and the rescreen has not occurred prior to the infant being 6 months of age, the infant will need an age-appropriate hearing screen. That decision will be left up to the audiologist. You do not have to make that decision. So if the infant is older than 6 months and still has not done the rescreening, then the audiologist gets to decide what type of hearing screen will be conducted. And you'll need to document in your note that the child was over 6 months of age and the audiologist decided to do XYZ rescreening method. So if the infant passes the rescreen in both ears, the case can be closed if no other needs have been identified. If the infant does not pass in both ears, the infant needs to be referred for diagnostic testing. And on your report to referring provider, you'll need to select which contact you're working on. So if they're now being referred for diagnostic testing, then you're going to be marking that this was the rescreen when you send in that report to referring provider. So if the infant is diagnosed with a hearing loss, your report to referring provider is going to be the diagnostic testing option. Be sure to document the type and severity of hearing loss, both on the report to referring provider and in your progress note, and you'll need to refer the patient to early intervention services. Again, just like with lead, you want to send that report to referring provider within 30 days of opening the case. You also want to send the report anytime anything significant happens in the case, like attending a diagnostic appointment. Now, we're finding a lot of times that we get a report to referring provider back that's not being done on the correct form. If you open up the report to referring provider and you do not have the option of questions like delivering hospital contact, rescreen, diagnostic testing, or early intervention, you're in the wrong report. Well, how do you get the right report? Well, you had to select you have to go back to your referral form. The report to referring provider is tied to the referral form. So if you've made a mistake on the referral form, you're going to generate the incorrect report to referring provider. So you will then need to go back to your referral form and make sure that you selected ADPH Central Office and that you selected newborn hearing. Those are going to generate the correct report to referring provider. There is a training with a lot more detailed instructions on how to do the hearing report to referring provider, and it walks you through what to mark on the referral form as well. This is on the on-demand webpage on July 12th, 2016. So what I do is I just go in and I click Distance Conference and Learning, I click On Demand, and then I click 2016, and you can scroll down to July, and you will find the July 12th, 2016 training titled Alabama Newborn Screening Program, Early Hearing Detection and Intervention. That training walks you through how to do your referral form, which generates the correct report to referring provider. And it walks you through how to do that report to referring provider. So if you still have questions about how to do the newborn hearing report to referring provider, I would refer you back to that training from July 12th, 2016. Today is February the 26th, 2018, which means that still has CEU time on it until July 12th of 2018. So if you need to renew it, if you need to view it again and you didn't get CEUs the first time, you might be able to get CEUs for it. So that's good. I like getting CEUs. That's important. So those were the major things that I wanted to touch on today. So I want to give you an opportunity to call or email with any questions, and we've got some email questions.
Yes, we do. I love Stephanie Lowry. Her question is, when we call the delivering hospital, do you recommend calling medical records or the unit where the babies are delivered? Stephanie's had some issues with getting medical records to give her the information.
Okay. This is when your knowledge of the local delivering hospital comes into play. You're going to know better what to do than I will. I know about the hospitals in Montgomery. I don't know about the hospitals in Huntsville and Mobile and Dothan. You're going to need to figure out what works best for you. But this question leads to why it's in protocol that you can also call the PMP or the ENT to get those results. If you do better calling the unit and getting the information that way, go ahead. If you do better getting it from medical records, then that works too. However you get the information is fine. It doesn't matter to me which way you do it, just as long as you're able to get it done. So if medical records isn't working, try the unit. But that's why we've got options in protocol, because sometimes the unit can get busy. So if it's easier to call the unit, you're welcome to do that too.
And there's something that might be helpful, just to piggyback something that you had said. On the newborn hearing website, ADPH website, there's the letter that explains what the law is that you can print off and fax to medical records. So it basically authorizes medical records to release that information.
If they're screaming HIPAA at you.
Yeah.
I think is where Melissa's going. So if they're telling you, I can't tell you that because of HIPAA, well, we have a letter that's available for you to print off and send in.
All right. And then can you provide some clarification in regard to when the care coordinator may need to touch base with someone in the newborn hearing program versus calling Diane or you, me, in regard to a question related to a newborn hearing or even a lead case?
Okay. You'll want to call the specific program when it's not specifically case management related. Example. So in newborn hearing, if you're not sure what type of method needs to be used, you could call me or you could call newborn hearing staff and ask them that. Maybe you're having trouble with a provider related to the type of testing that can be done that they're eligible to do at their specific office. That might be something that you would want to call the newborn hearing staff about. If your question is related to when is the report to referring provider due, that's going to be a question for the social work side of the house. So if it's protocol related, case management related, social work related, you'll want to call me, Diane, or Melissa on that. But if it's specific to a hearing issue or a lead issue, you'll want to talk directly to that program coordinator if it's not in the social work wheelhouse. You're always welcome to call or email me, Diane, or Melissa, and if we can't get the answer, we work with these ladies and they're just as nice as they can be, so we're more than happy to walk the 30 feet to their desk and ask them your question for you. So we do not mind if you send questions to us. We are more than happy to help and more than happy to get those answers for you. So anytime, you can always call us. Happy to talk to you.
We do have another question.
Okay.
Are hospitals notified? We will call them first, I guess, in regard to newborn hearing. This care coordinator says that she recently called a harried nurse at the hospital. Not a hairy nurse, a harried nurse.
A nurse that was really busy.
She complained that central office was making errors to cause me to have to call.
Well, and I don't think that we make mistakes. Yes, we always everybody makes mistakes. But it could be back to that issue that I spoke about when I started with newborn hearing. We're only sent the results once a week. So if the child delivered on Tuesday and failed the screening, the results came to us on Wednesday, child was rescreened on Thursday, those results don't come till the following Wednesday. So it's very possible that the child did pass the screening, which is why we ask you to call the delivering hospital to get that information. If you don't like calling the delivering hospital because the nurse doesn't have time, document that in the record that the nurse did not have time. So I followed up with the PMP and got the information from the PMP. That's why you have the option in protocol to do that as well. But document that you attempted or a reason why it was in your best interest to go ahead and call the PMP first. I just wanted to explain why it is that we ask you to do the delivering hospital first, because those results could be a whole week behind, and we're just trying to make it a little bit easier on you. But if it's easier for you to call the PMP, just document that for us.
And Meredith, I hope this question does not put you on the spot, but in regard to newborn hearing, and if you have a child who's been referred to early intervention services, you mentioned this in your PowerPoint. So they've been referred, and their appointment is 2 weeks from today. Can they just go in and close the case?
No. Protocol requires that you follow up and ensure that the child went into early intervention. Just because they have an appointment doesn't mean that early intervention has picked them up. Because what if they miss that appointment? So we want to keep that case open until that child has physically gone into early intervention and we can kind of, quote, hand off that case to early intervention for them to pick up. So you need to ensure that the child has actually gone into early intervention.
No more email questions.
We do not have any more email questions at this time. I'm going to give you another minute or two to call or email with questions. While we're still here, we still have some time. Again, we are turning off the 15-1 in Plan First effective March the 1st, 2018. You will code all of your face-to-face time for a high-risk patient, including the face-to-face psychosocial assessment time, to the 15-6. Your documentation will be coded to the 15-4. And again, there's a time limit on that of no more than 2 hours per patient per year. Any other questions? Yes, we have another one.
My friend Heather Smith. We have infants who can't get appointments for a diagnostic screening prior to 3 months for varying reasons. Also, if fail another screening and have to go back again, once an infection is cleared in these instances, we are well past the goal of the diagnosed by 3 months of age. 1, 3, and 6. As long as it's documented that the CC's been following up per protocol, are there any problems with being outside of the goal of 1, 3, and 6?
We can't control when a child has an ear infection. So as long as you're documenting it and following up as protocol states and continue to document it, then you're okay. I've got newborn hearing staff here. They're shaking their head yes. We prefer 1, 3, 6, of course, but we can't control ear infections. So just as long as you're following up with that family and encouraging them to take the child in as soon as possible, that's the best that you can do. Because we can't do things when they've got those ear infections, and we can't make mama take them in sometimes when they're sick. So we understand that. So just be sure that you document it. And again, we're striving for 1, 3, 6. That's the goal. Again, our job is best practice. We're here to tell you what best practice is, and that's 1, 3, 6. But if they can't get in during that time frame, just document it, and we understand that. Do we have any other questions? Nope. Okay. All right. Well, after we're done, if you have any questions, please do not hesitate to call or email us at any time. And see, I gave it another opportunity there.
This is a lead question. Does the parent have an option of refusing a home visit for a lead home assessment from the social worker?
There are very few things that I remember from graduate school, very, very few. But one of the main things that they drilled into my head in graduate school was the client has the right to self-determination. Yes, the patient can refuse. Mama can refuse. They can always refuse our services. Now, that is when a judgment call is going to have to come into play about a DHR referral. That's something you're welcome to give me a call about, and we can talk through it. I'm going to make a decision on a case-by-case basis as to when that needs to be referred out. Let's say that you get a referral on a child with a 40 venous sample and mama's refusing for you to come out. Ask her if she'll allow the environmentalist to come out. If she says no, then I'm going to tell you to refer that on to DHR because we've got to get that level down. If she allows the environmentalist to come out but not the social worker, maybe see if you could do some probing questions and find out. Assure her you are not DHR and you are not coming to take her child away, and that might get your foot in the door. But if she lets the environmentalist come out, document it, and at least get somebody in the home. But again, that's going to be a case-by-case basis on how we handle that. And again, the client has the right to self-determination, so mama can refuse that. But I'd want to know what that lead level was and try to figure out, why is mama scared of me? I'd want to do some talking with mom to figure that out. I want to remind you that there will be a quiz link uploaded to the on-demand page when I'm done. Those, you have to get 100 on the quiz, and there's a couple of questions just thrown in there just to remind you of some things. So if you'll be sure to take that quiz, those quizzes will be forwarded to your supervisor And that's the way that we track when you view trainings. So if you don't mind, please complete that quiz. The link will be on the on-demand page as well. And if you're watching this after the live date, the quiz link will be up there, and you can take it at any time and send that in so that we can track when you completed the training. Do we have any other email questions?
No, ma'am.
Okay. All right. Well, if at any time you have questions, please do not hesitate to call or email us. That's what we're here for. We will ask that you keep your supervisory chain in the loop so they are aware of what the questions are so we can all learn from that. We are happy to help. That's what we're here for. I want to thank you again for all that you do every day. You have a very difficult job, and taking care of our patients can be challenging, and you do it very, very well. Thank you for all you do. If you have questions, please do not hesitate to call or email anytime. Have a great day. Thank you.